essentially got the challenge of sort of talking about pain management issues in adult osteogenesis imperfecta, and in a way, obviously, what I've got is a presentation, but I'm very aware, obviously, that you've given up the time to be here. First of all, we just spend maybe 5 or 10 minutes just talking about types of pain that there are, because as we said, muscle pain, bone pain, there are lots of different sorts of pain. And again, one thing I've found in my practice is that sometimes when you present with pain to particular doctors, everyone just says it's the OI that's the cause of pain. And again, sometimes, in the same way that you'll have different causes of hearing loss, you can find that you may have something completely different to the OI that's causing the pain. People have just missed it, and sometimes you can do a really good job by finding these other things. So, I mean, pain essentially is a sensation that you don't like. Basically, that's what it is. I'm sure it's not rocket science. But basically, there's either damage, or there may, in some cases, that when you get acute pain, so if you do break your bone, you get that acute pain of the fracture. But then you can be left with chronic pain. And sometimes that can be that there's been damage that is persistent, so it may be that you've got a problem with the back, or you're developing some arthritic problems with your shoulders because of using chairs. But in some cases, with chronic pain, the damage is actually gone. So actually, there's no obvious tissue damage anymore. But it's almost like the nerve endings have become highly sensitive, highly amplified. So the receptors that are there, when they pick up the pain, or what the pain signals might have been, their things will become highly magnified. So for instance, if you're sitting down, and it's a really stimulating movie, you're watching, you don't feel any discomfort at all. You're able to switch some of those pain signals off. But if you're probably listening to me now, you're probably moving around a bit, feeling a bit sort of irritated, whatever. And so basically, we will all have these funny feelings. So depending on how your nervous system is reacting, your pain, the acute pain will disappear, but you can be left with chronic pain. So again, just sort of understand that there are different types of pain. And obviously the reasons that we feel pain, again, is that it's actually there for a purpose. Pain is not there, it's a nuisance, but really we developed it during evolution so that basically when we injure ourselves, we rest it, we recover, and then we're able to go and do things. And there obviously is some sort of brain response as to how you feel, and we know again, if your mood is low, pains are worse, they're worse in the middle of the night, etc. So there's definitely sort of brain functions that can go on there. Again, I'm just going to put this up. This just helps you understand, because again, if you understand a little bit about why you get pain, where things happen. So again, obviously at the bottom there, you've got the trauma, you've injured yourself or something like that. Chemicals are released from whatever tissue you've injured. Basically, that then sends nervous signals up through the nervous system to your spinal cord. That then transverses up to your brain and says, ow. And then depending on what happens, if like you're touching something really hot, obviously you're not going to carry on doing that. So there's then a signal from the brain goes back to where that leads and says, take your hand off the cooker. Basically that's what you need to do. So there's an element of all of that. And a lot of the treatments that are given for pain work either at the trauma end, so you've got things like your anti-inflammatories, so your ibuprofens, your diclofenacs, those sort of things to reduce the inflammation, reduce some of those pain signals. You've then got obviously sort of opioids that will act, so some of the sort of morphines, the tramadols, etc. They're going to be working more on some of the brain side of things. And then some of you will talk a little bit about other sorts of drugs that can actually interfere with some of the nerves, those signals that are being transferred. And also again, when you get the chronic pain, sometimes those nerve endings are still active even though the trauma is gone. So you're able to have some sorts of drugs that actually just interfere with the nerve signalling. They're not affecting the tissue and they're not actually affecting the brain. And actually, again, it's quite important for us as doctors and for you to tell us what sort of pain you're getting, because certain drugs don't work as well. So if it's more of a nerve pain or a muscle pain, you're perhaps less likely to respond to opioids-based medication, because they might actually end up making you worse. Whereas actually, so if you've got more of a nerve pain, a burning sort of sensation pain, then you're going to benefit better from some of the other sorts of drug treatments that are actually out there. So again, I'm just going to very quickly, and then we'll talk about there are four sort of types of pain. Again, we've almost described those to a degree. There's the ones that are actually more involved with nerve endings and receptors that pick up pain signals, which are on the left, and on the right you've got sort of the signals that are more sort of nerve related. So they're actually being generated internally from the nerve. There's no actual damage really that's going on. So obviously the first sort of pain is essentially what most of us are aware of. So that's basically when you've injured yourself, basically when you get these problems, and essentially that's where you get those pain signals. And those are the factors which respond a lot to, say, anti-inflammatories or to sort of maybe some opioid medication to a degree. The other sort of pain that you may get, and again, is actually nothing to do with your bones, it's actually more coming from deep inside you. So again, obviously that's if you're having a heart attack, but again, it could be that you're getting, you've got a problem with your gallbladder, you've got a problem with your pelvis, with your ovaries, and the problem there is that pain can actually be felt in different places. I mean, we're all aware that when you have a heart attack, you're getting heart pain, but you feel it going down your left arm. Whereas obviously also you could be having gallbladder pain, and it's in your shoulder. So actually sometimes doctors can get confused as to where your pain is coming from, because you may say, it's my shoulder that's really causing me some problems, and people think, oh yeah, it's because you've got OI, you're using your chair. But actually it may be that actually what you're really feeling is a colicky pain from your abdomen, and it's actually gallstones that is the problem, and it can be dealt with. So again, it's just being aware of, doctors being aware of what pain you're describing, and therefore what may be going on. When we just look at the sort of nerve pains, which are going to come up here, obviously again here, this may be, primarily will be when you've, say, got a radiating pain down a nerve. So this could obviously on this picture, the scheme there, it's basically sciatica. But again, it could be pain going down your arm. Again, but it's not a heart attack pain, it's because you've got a pinched nerve in your neck. So again, those sorts of things, that's where maybe the doctors will be looking at imaging, see if they can find a trapped nerve. But again, some of the nerve drugs work better rather than just dosing yourself up with lots and lots of tramadol and painkillers in that respect. And then the other sort of pain that hopefully you won't get, and again, I don't know if anyone has had this, but sometimes when you've had a fracture, say if you've broken a bone in your arm, or had a problem, say, with a lower limb fracture, you can sometimes have something whereby what's called the sympathetic system, so that's involved with heat control and sweating, and you get funny changes. And there you can see sort of that sort of patient's right foot has become very swollen, very red, and that can be quite a difficult condition to treat, but again responds quite well to nerve-related treatments. So again, so has anyone suffered with that? So it's either called sympathetic dystrophy, CRPS. Anyone had any of that with any of their fractures? That's good. Okay, that's great. I mean, it can be a really difficult problem in some individuals. Okay. Right. So hands up here. Who suffers with pain? Yeah. Okay. So almost everyone has got some degree of pain. What's interesting, if you go on to some of the medical sort of literature websites, and if I wrote it, I put in search terms. I put osteogenesis imperfecta, adult, and sort of quality of life pain. Okay. What I was able to get from that was basically one study has been reported in the literature. Okay. So it's almost like we all know that you've sort of got pain, but actually understanding it and understanding the impact it has is really poorly reported in adults. In children, there's quite a lot of data out there, and as we've heard, sort of regarding the drug treatments and what they do. But in adults, it's actually quite limited. This was the study. This was in 30 patients. That's all it was. We've probably got that here. We could almost do a quick sort of paper. I could just send a sheet of paper around, and we've got a publication. But basically, it was only 30 patients, mean age of about 30. Half of them reported back pain, and I bet there's more of you here reporting back pain. And what they've got, again, as Nick alluded to when he was talking, saying that one of the problems we've got is they use a questionnaire called SF36. That's used a lot in a lot of research to try and identify what impacts conditions have on people's quality of life. The problem is it's not specific for people with OI. And it's probably not necessarily that good. It will ask questions that are probably either not relevant or difficult to actually ask and to answer. But it's the best we've got. And essentially what you can see is that sort of black sort of banding, or that black block there, is almost the difference between whether they were classified as US normal or the OI. So you can see there's a mismatch, that the OI group is scoring lower, which means that they were reporting basically less good physical function, less good physical role, less good bodily, they had more bodily pain, but actually their overall assessment of their general health was pretty much the same. Okay? So that's either that, that the US norm is actually a bit of a weak group, and not actually, that they're a bit wimpy, or the OI people are actually pretty stoical, and actually despite those other things, they get on with life, etc. And I think I'll give the fault for the latter, definitely. But it's really poor. We don't have really, really good data. And that's going to make it hard when someone was asking, and one of the questions we're going to deal with, do the drugs that we have for osteogenesis imperfecta, do they actually help with pain, etc.? Because we have a really poor system of what pain's like naturally, and therefore actually trying to prove that it makes a difference is actually even harder. So again, it's a very poor area. So again, something I think there's a big drive to try and collect more data systematically with either registries, etc. And if we can do that, then we can start to sort of improve outcomes, etc. Okay, so what causes pain in OI? I mean, you've probably all got your own views. This is just, again, obviously the main one you're going to get is obviously the acute pain of a fracture. And obviously depending on how that fracture is treated, what part of the body it affects will determine what happens, whether it's just an acute event that's gone or whether there are problems afterwards. If obviously the bones become misshapen or you develop scoliosis, etc., you are probably going to get more, you may then get local irritation of structures, whether it's muscles, ligaments, etc., which will give rise to pain. You may develop then arthritic changes, and again that can lead to some problems. And I think again one of the biggest, a pain or a symptom, etc., is this more general bone pain, this general feeling of pain that you actually have. Is it lots of microfractures, just little fractures that are happening that will never show up on x-rays? Is it something else? I don't know. And again, we can talk a little bit about that, I'm sure, during sort of any further questions. But again, it's one of those more difficult to put your hand on, but actually the more people we see, it's one of the big things. And again, it's one of the things that I think the treatments do work for, but actually, it's something that's actually quite important. Anyone got any other causes of the pain specific to OI that you think I've missed? Because you've got the condition. Anything that you think of that might be different, that is other causes that we're sort of being missed, or not? Yeah.
The basilar pain.
Okay, yeah. So basilar invagination. Yeah. Okay, so that would be a so. I suppose I would call that's probably a mechanical. I mean, it is a mechanical pain.
Yeah.
To a degree.
It affects all the nerves.
It does. Yeah. So again, so you're getting two things. So it's a mechanical problem. It's causing compression on things. In that situation, under the treatment, you wouldn't. In that situation, you're getting those sorts of neck pain with radiating symptoms. That again would not be a pain that we would then be saying, "Gosh, just keep taking the painkillers." I mean, that would obviously be then you'd need some surgical stabilisation and correction there. Yeah. Sorry. Do you want to say anything else?
I was going to say after you've had the stabilisation, like I had, you get a lot of nerve pain.
Yeah.
Like nerve irritation.
Yeah. Yes, that's right. So again, so even when you've done the operations, you can still then be left with, one, you've got, probably the anatomy will never be completely normal, and therefore there will be some irritation of structures, and then again, if it's nerve pain, some of the nerve agents probably are better than the standard painkillers. Yeah.
You've all a little bit answered our question, but it was to do with post-operative pain after a surgical procedure, and pain that can be left as a result of that.
Sure. Yeah. I mean,
especially when you put the screws and rods in.
Yeah. Yeah. There's obviously again, and you've obviously got the initial pain after any operation, and you've got initial tissue damage. And again, you know, obviously the anaesthetist is getting better at how they can manage that pain immediately post-operatively. But even when you've had a surgical correction, you know, you may find that you've still got some pain. And again, trying to work out, is it due to persistent tissue damage or pressure on structures, or is it again due to the fact that, you know, that you may, after a while, have had sort of the nerve just become hypersensitive around that area. So if you've always had trouble with, say, an elbow, and you've had it for years, and you've had an operation, eventually the nerves around that elbow, any minor irritation, it becomes so magnified that the brain, you know, thinks it's about to drop off, and so sometimes, you know, again, some of the nerve drugs can work in that regard. Yeah.
Which category would you put kind of soft tissue tendons in more time?
Again, I mean, probably, it's going to be more of a, I mean, that's probably more of the sort of first sort of pain, as in because you know, it's the tendons have a nerve supply which will then signal to your brain. So more of that would probably be sort of either tissue damage or other problem. And again, the other problem again that we know with OI, because of the nature of the collagen structure, that obviously when you're younger, particularly your ligaments are more supple, and so again we know that can predispose to joint problems, etc. So I think it's probably more that, but again it's understanding. I mean, at the end of the day we'll talk about with some of the medication again. Someone said, what's the right medication? Well, the right medication is the drug that works for you. And although that's a bit, you know, you might think that's a bit stupid, it's obvious, but of course it is. But actually, sometimes it's actually also having the courage to say, if you think certain drugs aren't working, to stop and to then, you know, change tack. Not just to keep taking more and more and more of the same. Sorry?
The hyperflexion.
Yeah.
Means to make that worse.
Yeah. Oh, sorry, so, yeah, sorry, so we know again, in sort of, so if your joints are more mobile and go through a longer range of movement than they should do naturally, then actually those joints are going to be more predisposed to getting fractures. So again, when you're younger, a lot of, you know, children, adults, either children with OI or with high mobility, it's a nice party trick to be able to put joints in funny places, but actually that is doing your joints a bit of a disservice over the years, and things will actually so the joints can get damaged. So, regards to management strategies, okay, obviously before you get bombarded with drugs, it's always worthwhile, you know, trying to make sure that people are looking at you holistically, I would say. And again, if you're lucky, you would get access to sort of a multidisciplinary team. And again, Nick was alluding to, you know, we haven't really researched upon, you know, how good, you know, physiotherapy, OT, etc. is, but trying to basically look at everything in its context. I mean, where I work, we have a very good pain management program, you know, with regards to physios, OTs, psychologists to help. And again, it's a shame that the psychologist was ill. But again, learning those sorts of things. If you've got specific, or if the back's a particular issue, we know there are lots of things they do. So again, there's an awful lot just being aware of, you know, why you've got the pain, what structures might be involved. The more you understand it, the more in control people can be. And we know that if that happens, you're more likely to have a positive impact. I've just put this up. Don't try and copy it or dwell on it, etc. Essentially, this is what NICE, which is the organisation that's involved with rationing healthcare in the UK, looks at for osteoarthritis. So this is just its management plan for what you should do if you have an arthritic joint, probably knees, hips, etc. And essentially the idea is you start sort of, you know, at the middle, which is education, etc., and you just move to the outside of that circle. But lots of different things. Obviously, you know, the end things would be sort of related to you know, surgery, etc. But most of it is initially lots of other stuff to try and help. How many people in this room take vitamin D supplements? All right. That data, that bar graph on the bottom, is basically the proportion of people that would be classified in the UK as having low vitamin D levels. Okay, but below 50 would be classified as low, and about 40% would be low. Okay, and if you come from sort of Glasgow, Dundee, you've probably got even lower than. But again, and there's interest that vitamin D deficiency. One, I think from a point of view, again, we were talking about, if you're on bone protection treatment, you probably definitely ought to be on vitamin D at least. You can get your calcium in the diet, okay? But vitamin D is difficult to get in the diet. You do get it from sunshine. But also there's interest that vitamin D might actually help with bone pain, muscle strength, etc. So I would be thinking that, unless you've got a history of kidney stone problems, you probably should be on vitamin D. It can be tested on a blood test, and it can be given accordingly. But I think from a sort of, one, because it might affect your pain, but it also, we know, it does improve muscle strength, and it would be worthwhile being on vitamin D. So again, just to give you a bit of a sort of game show sort of thing, to get enough calcium in your diet, you need about a pint of milk. Okay. How much milk do you think you need to take to get an average amount of vitamin D per day? What do you think? Who would say 2 pints of milk would give you enough vitamin D? Higher? Okay, someone said higher. How high do you want to go then? Put your bid in.
8 pints.
8 pints. Okay, so someone's going to drink 8 pints of milk a day to get their vitamin D. Anyone want to go higher or lower? Very conservative group at the back. Anyone want to offer a...
I'm not sure if it's a trick question. How actually got vitamin D at all?
Oh, clever at the front. Okay, I'll let you into a secret. Okay, that's right. Anyway, actually, there isn't much vitamin D in milk. It's dependent calcium. You probably have to drink, to get the equivalent of one of those horrible chalky calcium tablets that some of you might be on, you probably have to take about, I think it's about 40 pints of milk to get enough vitamin D. In the US, vitamin D is added to milk. But vitamin D is in fish, vitamin D is in eggs. But you have to eat about 8 eggs a day to get enough vitamin D. And you probably have to have about fish twice a day. So in other words, it's actually very difficult to get vitamin D in the diet. That's the bottom line, okay? And if you live up north, you're not going to see the sun, and so therefore, I would be saying, it's highly likely that a higher portion of us are going to be vitamin D deficient or inadequate, and that actually, from a bone perspective and maybe from a pain perspective, it would make sense to actually be on something. Okay, that's my sort of little take on that. I'll just skip through that next one. That's fine. Okay. So, when we talk about pain, the WHO has got this sort of pyramid, ladder, whatever you call. Most pain ladders and pain management pathways have actually been designed on the back of cancer treatment, as in the type of pain you might get from cancer that spreads a bone. So you start at the bottom of this, and the ideal thing is that you should work up. Okay? And that actually is what most of your doctors will start with. So they'll initially, tell you you've got backache. They might suggest that you take some paracetamol and non-steroidals, and then they'll move up through this ladder. Okay, and as you can see, this is very much, there isn't anything about nerve pain in this ladder, so the nerve drugs aren't included. So it's very much focused on non-steroidals, codidromol, tramadol, and then morphine, essentially. And that's essentially how most people sort of work. And obviously the problems is that all those drugs have potential side effects. So non-steroidals, you can buy them over the counter. At least you can buy ibuprofen. Obviously the other ones you can't, or you can, but at lower doses. So I think diclofenac you can get over the counter, but at a lowish dose. Problems, I think, are gut-related complications. So it can cause bleeding. You can sometimes get some puffiness of legs, And again, if you've got a history of asthma or chest problems, some people may not want to take them, again, because they've got certain problems there. Again, there are some, what are called these COX-2 inhibitor ones, so that would be our Coxia or Celebrex, if any of you take that. Those are thought to have less gut-related complications, but they still have some. And again, most people would not like you to be on a non-steroidal long-term, because people have actually just thought there may be some cardiac heart risks associated. So again, as you get older, people may not want you to be on those sorts of things. So again, it's a difficult area, but it is they are used a lot, and obviously a lot of you will self-medicate with them. Opioids, again, essentially, if you're on them, you're all taking hard drugs to a degree. Essentially, again, if they're not working, stop them. In some cases, the opioid treatment might actually be giving you more of a problem. There's been a lot of interest in sort of, some of these drugs actually giving people chronic headaches and other problems. And so if you can, if they're not working, stop them, okay? Because otherwise you're going to run the complications. Again, and I think from the patients I treat, I would say one of the big worries I would have with these things are the side effects they may have, particularly things like constipation and abdominal pain, and it may actually cause more of a problem. So I don't, again, you can answer more about that. The nerve drugs. How many people anyone on any of these drugs? Gabapentin, Lyrica, pregabalin. Yeah, at the back there, someone's on that. Again, these drugs almost started off as anti-epileptic medications, and then people discovered that they actually had an effect on sort of helping with pain, and they work quite well in some individuals. And again, you can use them in sort of in combination with the side effects, drowsiness, and weight gain. So again, those are those can be problematic. Again, I don't, as we sort of said, I think in all cases with pain, if you've got depression on top of it, anxiety, then that can cause problems. And actually, again, sort of low-dose antidepressants can help. And again, it's not always people aren't saying that you're really severely depressed, but sometimes just even these low-dose antidepressants can make a difference to the pain. And sometimes what you're trying to do sometimes is just break the cycle. If you've got a constant cycle of nerve endings being stimulated, brain being told you're in pain, it can just self-correct. If you can just sometimes break into that for a few months, in some cases, if you haven't got permanent damage, you can actually do quite well, and then you can move on. Okay, I'm just going to skip through topical treatments. Are again fairly similar. Again, there's lots of topical creams, things you can rub in. On a bit of time, I'm just going to skip through things. Complementary medicine. Again, how many people here have tried any of these treatments? You don't have to own up to which one. Hopefully it's more the top group. I suppose many are having chronic hydrotherapy. But sort of, I'll just make, okay, so we're just doing a straw poll. Is that a question or just doing something else? Okay, fine, okay, just missing one of those things, but I won't hold you to it. So, okay, yeah, and I think the bottom line here is that, we don't understand how long all these treatments work, but they do work in some people. Therefore, if it's working, stick with it. I really, I think that's fine. I think the important thing here is, always tell us what you're using, what you're trying. I think the important things are, make sure that who you're seeing is reasonable, understands your condition. I say at the bottom line, be aware. Just be. If someone says, all the other drugs we're giving you are complete rubbish, be a bit sceptical. I mean, at the end of the day, we've got to work together. I don't think there's not necessarily them and us. It's almost like let's come together. Otherwise, you're going to get into a problem. Okay, so managing pain after a fracture. Again, simple things. Again, for those of you that have had, say, spine fractures or problems like that, we used to find calcitonin in some patients worked quite well. It's a shame that it used to be available as a nasal spray, which was quite a simple way to administer the treatment for individuals. You might take that for, say, 4 or 6 weeks, and it would help with the pain after a fracture. What unfortunately happened was the European regulatory authorities took the drug off for sort of more long-term use, so removed the nasal spray. It's still available as an injection. You can have subcutaneously in the skin, of course that's a bit of a pain, you know, to necessarily work out the administration. Is it going to be given by your GP? Is a practice nurse going to come through? Are you going to be taught to give yourself a little jab? It can be done, but again, in some people, immediately after a fracture, that can be quite useful. Extrapolating from, let's say, the osteoporosis world, which again is what we said a lot of these drugs are used in and where we extrapolate. In osteoporosis, if you've had a fracture, particularly of the spine, and you have a shot of comedronate, it will help with the pain. So again, we would be thinking that if, you know, it was a newish presentation or something was happening, you know, there isn't a concern about it delaying fracture healing, it might actually be a useful thing to actually do. Okay, this just shows that naturally. We normally say to patients, if you have a fracture, say a spinal fracture, it might take 6 to 12 weeks to actually, for the pain to settle. This is just some data suggesting that actually, this is again from osteoporosis, that actually it might take a little bit longer. For people with mild OI, if you have a spinal fracture, there's a technique where you can put cement into the fractured bones. And that's actually happened. This is a case report of a patient that had it done. It can help with the pain. The worry, I think, if your bone is more brittle and soft, that actually if you've got that white blob there is actually hard cement. If you've got really hard cement and you've got bones above and below that are a bit softer, what's going to happen? You know, what are going to be the issues? But again, talking to Nick Bishop last night, he was saying that, you know, sorry, for the children, you know, the bones are growing, but some of them have got bits of holes left in them. And again, you could think, well, maybe at some point you want to fill those in. I don't know. But again, if you're having intractable back pain, this is a possibility. And again, it's very, very early days, and we'll have to wait and see. But again, I think there are some concerns about leaving that blob of cement in there. So, the $6 million question, does bone protection treatment reduce pain? Okay. What about the bisphosphonates? What about parathyroid hormone? The issue here is that, again, extrapolating from osteoporosis, alendronate has been shown to reduce the rate of back pain in ladies with osteoporosis. If they were treated with, say, Fosamax, they had less back pain than patients that didn't receive it. Okay? When you look at parathyroid hormone, PTH, again in osteoporosis, the dark line there is basically the people with reporting back pain. There was less back pain in patients with PTH treatment. Okay? This is osteoporosis, not OI. Okay? And you can see that line also starts to come apart after about 6 months of treatment, not 6 weeks. I mean, that was obviously from the bisphosphonates for some of the OI. So the drugs in osteoporosis seem to work with reducing pain. Okay? In OI, the data is really small. Okay? This is the only data where pain has been reported as an outcome measure. Okay? So there's not been a lot of, although you all put your hands up, I've got pain, whatever, the number of studies that have actually looked at whether the bisphosphonates in adults reduce pain is really small. There have basically been 2 studies, alendronate and residuate. They didn't show anything. Okay. Now again, I know anecdotally that when we give comedronate to a lot of patients, you will feel less pain. That's what you report. But it hasn't been documented adequately. So again, we don't know for certain, but the general feeling is that it does. But I think that we need to capture that data more robustly. And again, this concept of maybe you're going to be on the drugs for a while and then stop and then restart. So again, those are sort of things that I think we need to actually work on. But the data is actually fairly limited. With regards to PTH, although, as Nick said, there's been a study reported showing effects on bone density in patients with OI, there was no data, or no outcome data with regards to pain and quality of life. So although you'd imagine if you were preventing the fractures, then you should have an effect on doing that. We don't know for certain. So it's a little bit, it's unclear. Okay, so that is what I've discussed. We've had some questions. I think we've got about 5 minutes for any other questions, areas that I have missed. So question at the back, I think.
I've got quite a lot of neuropathic pain, which is something that's been quite recent, and I got referred to neurology for them to try and manage it, and I'm just basically getting bounced about from consultant to consultant. I've now got, I think, about 7 different consultants that I see, and nobody's actually really looking at it or talking about it. Everybody else is passing it on to somebody else. Who should see me? Who's the best specialist for me to go to something like that? Because nobody's really taking responsibility for it.
That is. You shouldn't have 7 consultants. Involving care. Because although we like a multidisciplinary team, that's taken to an extreme.
As well, and you never ever talk together. They all write letters to each other.
Yeah, that's right. So a multidisciplinary team works well when everyone's in the room at the same time and you get a consensus. There's no point bouncing things around, as we discussed about with some of the hearing tests and the balance. If people start disagreeing amongst themselves, ideally, obviously you should have, hopefully your bone specialist who's involved with your overall care. Most bone specialists, unless they're orthopedic surgeons, most bone specialists would be able to tackle quite a lot of that. I'm quite happy myself to tackle quite a lot of the pain management issues. You only really need to bring in some of most hospitals will also have a pain clinic of some degree, who may also just help with interactions of drugs. The most you need is 2. I would have thought 2 people. You shouldn't then need a neurologist and whatever. It should be, but again, I think what you've got to do is identify your almost your champion, your main carer, and then sit down with them and discuss where you're going with it. That's what I would do. Yeah. Question next to you, and then we'll come to you.
What are your thoughts on? I was told by a pain management clinic at the Royal Berkshire Hospital in Reading, where I'm based, that keeping a steady line of opiates such as tramadol and codeine constantly, whether you've got a fracture or not, but obviously a smaller dose each day, it's good to keep that level in case you fracture, because then you've got that baseline, and then you up it, because you said about don't take them if you don't need them, which I agree with. But this is what I've been told by pain management, to keep this low level, so if I fracture I've got that base level and then I can boost it.
I suppose it would depend on how frequently you fracture. So if the fractures were happening very often. Not frequently. No. And in between fractures, if you stop the opiates, would you have much pain or not?
Just generalised everyday pain.
Right.
Which.
Can you cope with it? If you could cope with your everyday pain without needing big doses or doses of even a minimal dose of opioid, I would try and stop it. Because I think there are side effects with those drugs, and also there's dependency and things like that.
The dependency was what I was concerned with.
Yeah, so I would always be saying, if you think you can function, I would be off it and just use the opioid for that much more severe pain when you've got the fracture, because then you can just have a bigger dose of that and then wean it off. That's what I would try and do.
I break ribs a lot, but they're not major fractures for me, personally. So, I just I might cope with one week, but then have a bad fracture with my ribs, and other weeks I would have to take.
And again, I would almost be thinking, could you manage the pain of a fracture? Could you have would it be a 2-3 week course of, say, calcitonin? Could you add in something like that as well? Okay. Work out a strategy for dealing with the fracture pain and then go from there.
See, yes, and that has been discussed with me about that, so that's worth knowing, thank you.
Yeah, okay. There's a question, lady there.
Yeah, I suffered chronic back pain or kyphosis, so my back was in bits for years. And I went to the orthopaedic and he was like, nothing you can do. And so I said I was going to physio. He didn't seem too happy with that, but I did. And then, now it took over a year, and 2 physios later, I got rid of my back pain. I then did the physio every day, stopped doing it. Guess what happened? Back pain comes back, so now I've been doing it and I'm up to 30 minutes a day, which includes back, legs, everything. I used to get very bad circulation in my legs, so all of that. And as a result of the physio, I've also improved bone density in my spine by 60% in 3 years.
That's great.
Yeah.
Okay, I think that shows you don't need drugs in all cases, and that's great. So it just took a year to get the referral and get seen.
Oh no, I got seen. It just took a year to get rid of the back pain.
Oh, okay.
All over.
Okay, fine. Okay.
Yeah. It's fine.
That's great. I think that just emphasises that those sorts of other modalities, again, but we don't have a really strong handle about how effective it really is. I think that's one case, and what's the right strategy, what's the right advice, recommendations. Again, that's always, the more we can get that information, the better. Question in the front here, yeah.
So I've just, as a sort of a response, sorry, as a response to the last question, I've actually been advised for certain pain not to do physio. I've had lots of different professionals saying to me, oh, why aren't you doing physio? No, you shouldn't be doing physio. Yes, you should be doing physio. And you sit in the middle and you think, well, I'm 25 and lazy. If I'm going to make a choice, I'll choose not to. But I don't know medically if that's the right choice.
Yeah, I think the difficulty here is, obviously it depends what structures you're trying to put the physio through, whether it's for your spine, whether it's your shoulders, etc. And also it's making sure that your therapists are aware of your condition. Because what you don't want is someone to be over, that they can't treat you as they treat every other individual. And as we said, we try to individualise your care. And again, I think part of meetings like this and whatever is the fact that we need to engage you with therapists just outside. Because again, we've obviously you've got good therapists for the children at the sort of the main sort of big centres, but it's actually making sure that there's then that information is disseminated, so it's available, yes, at the big centres for adults, but at the same time it goes to other hospitals, because the training that a general physio would receive in OI would be nothing. So it's actually trying to work that out. So again, I think it's sitting down with your professional person that looks after you, and at the same time then identifying the right physio. Again, sometimes it's difficult if you're visiting people in Sheffield or London, and then they say, well, you've got to have physio weekly, that's going to be back at your local base, and it's trying to make sure all of that is joined up and is appropriate. So it's a challenge to us as professionals, and to make sure it happens better, probably. Any other questions? We sorted you all out. So we'll ask you all to fill a questionnaire, and on the way out we'll get paper done. Great, I think lunch. Is that correct? Thank you very much.